Thank you. So good morning, everyone. Before I start, I would like to thank the Scientific Committee of SASLT for this kind invitation and to thank all the audience for attending today. I was assigned to talk about Covert HE, the hidden disability we keep missing. I will start with definition of hepatic encephalopathy in general. It's a brain dysfunction caused by liver insufficiency and or portosystemic shunting, not a structural brain lesion. It presents with a wide spectrum of neurological or psychiatric manifestations. And as we know, the pathophysiology of hepatic encephalopathy, it's complex with multiple components. It's basically, we have three main theories. The first one is about ammonia. And we know the ammonia mainly generates from our diet, from bacterial metabolism of protein, and from deamination of glutamine by glutaminase. And over ammonia, and after the ammonia accumulation in the body, the liver would just convert the ammonia to urea and excrete it in the urine. In case of liver insufficiency, the ammonia will accumulate in the body and cross the blood-brain barrier, which leads to brain edema and further hepatic encephalopathy manifestation. More ammonia exposure lead to further physiological disturbance, like the ammonia will combine with the ammonia will combine so the ammonia will just enhance cytokinase production, and this will lead to further brain edema and brain damage. And also, as we know, liver cirrhosis is a pro-inflammatory state which lead to liver inflammation and microbiota activation. This will trigger dysbiosis and further neurotransmitter release in the brain and further hepatic encephalopathy manifestation with brain edema. So EASL and ASLD classified the hepatic encephalopathy depends to the primary cause to three types. Type A is usually occurs with acute liver failure. Type B results portosystemic bypass or shunting. Type C is the one with liver cirrhosis. And hepatic encephalopathy, clinically, it can be stage 2 either by use West Haven criteria or Aishan classification. Aishan is standard for International Society for Hepatic Encephalopathy and Nitrogen Metabolism. I will mainly focus in Aishan classification. They classified hepatic encephalopathy either to covert, which is equal to minimal, or stage 1 in West Haven, or overt, which is stage 2 and above in West Haven. So the incidence of hepatic encephalopathy overall reach up to 70% in case of liver cirrhosis, and the covert can reach up to 85% with liver cirrhosis as well. And we know those patients who underwent TEPS procedure has a risk of develop hepatic encephalopathy, and the risk reach up to 50%. Those with primary muscle and alcohol-related liver disease has higher incidence of hepatic encephalopathy than others. Usually we keep talking about the stent diameter or prophylaxis before or after TEPS procedure to decrease the risk of hepatic encephalopathy or to treat the hepatic encephalopathy. This oral presentation was in the latest ASLD meeting, and just to summarize it, ALTA study was a multi-center prospective cohort study. They enrolled around 719 patients who underwent TEPS procedure. The average follow-up was for around 379 days. The primary outcome was to develop severe hepatic encephalopathy, which was defined by 2 and more HE-related hospitalization. The conclusion was severe HE occurred in up to 17% of patient post-TEPS. The patient clinical factor predict the severity more than procedure factor, so stent size and prophylaxis lactulose or rifaximin not considered as a predictive factor for the severity. So HE risk can increase over time, and the first episode usually develop within the 5 years of liver cirrhosis diagnosis, and the rate of recurrence increase in the first year and reach up to 40%. So what is covert hepatic encephalopathy? Covert is subclinical brain dysfunction and cirrhosis without any overt manifestation. There's no single biochemical test to confirm the diagnosis. Ammonia alone has no diagnostic or prognostic factor for covert HE. Covert HE has significant clinical impact and safety risk in cirrhotic patient. It impaired driving ability, it's reduce work performance and alter emotion regulation. It can increase risk of falls and affect quality of life by poor sleeping quality and affect the daily living skills. So, should we screen all of our patients for Covert HE? Ideally, we need to have at least baseline test for all cirrhotic patients, with a priority for those who has significant reduced functional or work performance, those with neurocognitive symptoms, or who has driving or safety concern. This abstract from the last meeting, it was about association of covert hepatic encephalopathy with non-elderly and muscle patient with liver cirrhosis and SCC. It was a retrospective observation study of 195 patients with cirrhosis without any overt manifestation. Covert diagnosis using Stroop test, I will talk about it later. The conclusion was covert HE affect approximately 1/3 of cirrhotic patients, and patient below age of 65 years muscles is the dominant driven for covert encephalopathy, while in elderly, covert risk cluster with SCC and high ammonia level in blood. So can we detect covert encephalopathy, hepatic encephalopathy? Yes, we can. We have different validated diagnostic tests. It falls into three main categories. I will cover them briefly. The first category is paper and pencil psychometric test. We have the second category, computerized and digital cognitive test, and we have a neurophysiological test as well. This is general principle before assessing any patient. Just select the correct patient, those cirrhotic without any overt manifestation, exclude other cause for any neurocognitive impairment, and prepare quiet environment while you are doing this test. The first category of paper and pencil psychometric test, I will go through the psychometric hepatic encephalopathy score. Basically, we will give our patient 5 papers to complete it, include 2 number connection tests, 1 digit symbol, line tracing, and serial dotting. We will just calculate the total score. It has high sensitive and specific value. It's limited because it's time consuming and may be affected by age and education, and it remains the gold standard for covert HE in clinical trials and guidelines. The second test under the same category is repeatable battery for assessment of neuropsychological status. Again, our patient will ask to complete 5 tasks to assess their memory, the immediate and delayed memory, language, attention, and visual. It's a very strong test. It's limited because it requires psychologist assessment. It can be used in selected research center and can be used as transplant evaluation as well. The other category is computerized and digital cognitive test. ICT, it's inhibitor control test. It measures the attention and response inhibition. Patients will be asked to press a key for correct letter sequences and avoid responding to incorrect ones. It's limited because it requires computer, is still used in research center mainly. The second common test that used under this category is Stroop test, and we have Encephal app Stroop. It's a smartphone-based cognitive test that assess processing speed and cognitive stability. A patient can identify the color of words while ignoring the written text. Like if we can see if the yellow is written by the green color, and we'll ask the patient which color is this, maybe his memory will answer it's yellow while the written is by green. So it has very strong negative predictive value. It's fast, free, and can be used bedside in daily clinic. It's limited because it can be affected by color blindness and visual impairment. It's preferred use in a clinic as a screening tools. So the third category is neurophysiological test. EEG is commonly used, but mainly to exclude alternative diagnosis of neurological impairment. It's not recommended for covert screening. We have a critical flicker frequency test serve as an objective marker for identifying covert HE. It measures cortical visual processing. It's a very strong test, and it's limited because it's need equipment availability. It's alternative tools in a specialized center as well. So this abstract was in the latest meeting as well. They use the beacon at-home self-administration of a test for critical flicker frequency as a screening test for minimal hepatic encephalopathy. It was a prospective study, involved 21 serotic patients. The study evaluates self-administered CFF testing over a 6-week period, and showed significant patient adherence and with good promising result. So moving to the management of hepatic encephalopathy, the management of covert is almost like the management of overt hepatic encephalopathy. Our goal mainly to reverse cognitive dysfunction and reduce circulation ammonia, prevent further progression to overt encephalopathy. And this algorithm showed the general principle of hepatic encephalopathy management to start with identify and treat the cause, and then add on the first line therapy, which is lactulose, and to titrate it, targeting 2 to 4 soft bowel movement per day. Rifaximin is second add-on therapy after the first recurrency or after the second episode of hepatic encephalopathy. In case of ICU and severe hepatic encephalopathy, rectal lactulose is recommended. If there is no response, assess the patient for large shunt and possible embolization. Probiotics still under study, and small data approve the probiotic in covert hepatic encephalopathy. It has significant impact on driving ability and cognitive impairment. Liver transplantation remains the best for refractory cases with significant decompensation. So do we have any other medication? Yes, we do have medication under investigation to lower the ammonia level. We have L-ornithine L-aspartate, or LOLA. We have ornithine phenyl acetate, and we have glycerol phenylpitrate. It's ammonia lowering agent. The LOLA is oral and IV. The OB is IV medication, and the GPP is an oral medication. It's still not a standard of care, but can be used to lower the ammonia, and it helps. And albumin-based therapy has widely been used, especially in case of acute liver failure, as bridging to liver transplant. It can be used as IV infusion or dialysis. It's not a standard treatment for hepatic encephalopathy, but it can help as well. Nutrition-based therapy is highly recommended. Zinc supplementation has been used, but just to let you know, zinc is recommended in case of zinc deficiency only. The data are limited in hepatic encephalopathy. And for nutritional support, and as we know, the recommendation for cirrhotic patients is for daily protein is 1.2 to 1.5 per day to maintain muscle mass. BCAA may improve hepatic encephalopathy, but no mortality benefit, and we have to maintain adequate calories, avoid prolonged fasting, and support sarcopenia prevention. And this is actually my last slide about the fecal microbiota transplantation in hepatic encephalopathy. It mainly restores gut microbial diversity, target the gut-liver-brain axis. Small RCTs in recurrent HE showed significant improvement in cognitive performance with decreased liver-related hospitalization. There is no serious adverse effect. The benefits sustained up to 15 months, evidence early and limited, and used only in a clinical trial or an expert center. So my take-home messages today is Covert HE is common and under-recognized, affecting more than half of patients of cirrhosis. Covert HE predict progression to overt hepatic encephalopathy. Simple validated screening tools exist. Early recognition usually better to prevent further progression. And thank you.